Good evening. It's now 6 o'clock. I'm handing over to Benita Naidu. Benita, over to you.
Good evening, everyone, and welcome to today's medical coding webinar. Can you hear me? Good evening, everyone, and welcome to today's medical coding webinar. My name is Benita Naidu, Acting Head of Unit of SAMA Coding Department, and I'll be facilitating today's session. We are delighted to have you join us as we explore key updates and best practices in the correct usage of ICU and emergency consultations, as well as color Doppler. Our goal is to provide practical insights that will support accurate, efficient, and compliant coding. Before we begin, just a few quick reminders. This webinar is being recorded and the link will be shared afterwards. Please post your questions in the chat. We will have a dedicated question and answer segment at the end of each session. CPD points will be awarded after completion of the post-webinar questionnaire. We encourage participation. This is a great opportunity to clarify coding nuances and share experiences. With that, let's get started. Please join me in welcoming our first speaker, Ms. Deshri Munian. Deshri is a medical coding specialist at SAMA with nearly 20 years of managed healthcare experience and including 12 years of coding experience. She's also a professional nurse and holds a Bachelor of Commerce degree as well as a project management certificate. Over to you, Deshri.
Good evening, everyone. Thank you, Benita, for that great introduction. I don't have anything to add to that. So for those of you who don't know me, my name is Deshri Munian, and like Benita said, I'm one of the medical coding specialists here at the South African Medical Association. And this evening, I will be presenting on the correct coding for ICU codes, item codes 1204 to 1210. We're just going to look at clarifying the interpretation of the ICU codes in the medical doctor's coding manual. So I'm just going to...
Sorry, Benita. Sorry, Deshri, we're getting a bit of feedback from your microphone. There's a scratching sound coming through.
Okay, I'm not sure where that could be coming from. Are you still hearing it, Ranir?
Yeah, we can still hear it on this one.
Oh, no, I'm not sure where it's coming from.
Okay, continue. Thank you.
Okay, sure. Thanks. Just trying to project my presentation here. Can you see my screen?
The slides are coming up now. Just give it a second or two. Here you go. And then just put it in presentation mode.
Presentation mode, okay. Okay, there we go.
Here you go. Thank you.
Okay, so like I said, the presentation is on correct coding for ICU consultation, and it's for item codes 1204 to 1210. The contents of the presentation, we've been through the introduction already. And secondly, we're going to look into the category 1 ICU or high care code 1204. And then we're going to go on to category 2 ICU codes. That is the item code ranging from 1205 to 1207. And then the category 3 ICU codes, which is the item code range from 1208 to 1210. And then lastly, we're just going to have a question and answer session. we do have two panelists who will be joining us for the question session. Okay, so first up is the category 1 ICU or high care. This is the coding of the item 1204. So firstly and very importantly, for all categories of ICU and high care, that is category 1, category 2, category 3, the doctors must first discuss amongst themselves, and they must agree who will be recognized as the primary doctor, and on the category of ICU or high care to code per day and in each case. So for to code code 1204, it's for patients that are requiring intensive monitoring where physiological instability is anticipated. In such cases as diabetic pre-coma, asthma, gastrointestinal hemorrhage, and so on. According to Rule T, ventilation does not form part of Category 1 ICU or high care, as a patient is only intensively monitored in anticipation of physiological instability. There is no active system support required for these patients. And so ventilation forms part of an active system support. Therefore, the ventilation item codes 1212 to 1214 only forms part of category 2 and category 3 ICU codes, that is item codes 1205 to 1210. These codes require active system support. Okay, and then item code 1204 may not be coded by the surgeon who performed the procedure, as post-operative care is often included in the surgical global units of the procedure. The operating surgeon may code 0109, which is a hospital follow-up visit for a patient with a post-operative complication. That is a category 2 patient requiring active system support. The complication or the exacerbation of an underlying comorbidity that requires care other than normal aftercare, but provided that it is supported by an additional ICD that must be reported on the account. Cardiothoracic post-operative care is exempt from Rule G. The South African Cardiothoracic Society considers high care code 1204 after cardiothoracic operations as no ordinary aftercare, which is necessary for the safety of the patient, and they consider this to be a remunerable cost. It's often appropriate to move a patient to the high care unit after a period in the ICU. And code 1204 is chargeable only by one medical doctor per day. Only the primary medical doctor, who is responsible for the patient's post-operative care, may code 1204. All other involved medical doctors, including the operating surgeon, may code the hospital follow-up code, and that is code 0109. The same medical doctor may not use combinations of 1204 to 120. Sorry about that. The same medical doctor may not use combinations of item codes 1204 to 1210 on the same day, and item code 1204 may only be coded once per day, regardless of the number of times that the doctor has attended to the patient in ICU or high care on the same day. Just trying to get to the next slide. Okay, there we go. Okay, the next one is category 2 ICU, and it is the I code 1205 to 1207. The question is, when should it be coded and when should it not be coded? So the item code 1205 to 1207 can be appropriately coded when patients require active system support and when there is any intervention that is necessary to support a single organ system. And it is inappropriate to code item codes 1205 to 1207 when multidisciplinary team care is not required. And these codes are not appropriate for multi-organ failure. In the MDCM example that is set out, and we're going to just go through it. It explains the scenario quite well. Category 2 ICU care is applicable where a patient requires active specialized intervention such as ventilation, dialysis, inotrope support, blood transfusions, fluid resuscitations, and so on. And in cases which includes but is not limited to acute myocardial infarction, diabetic coma, head injuries, severe asthma, acute pancreatitis, eclampsia, flail chest, etc. Okay, we're still on category 2 ICU codes. That's item code range 1205 to 1207, and we're going to look at the appropriate coding for this code range. For day 1, the primary medical doctor may code 1205 only once. All other involved medical doctors may only code the hospital follow-up visit code, which is code 0109. And thereafter, day 2 to day 14, that is the subsequent days in category 2 ICU, the primary medical doctor may code 1206, and all other involved medical doctors may only code 0109. And thereafter, from day 15 onwards, which is the further subsequent days, the primary medical doctor may only code 1207. All other involved medical doctors may only code 0109. Okay, and then the add-on codes, that is the code range 0145 to 0147 and 0126. These codes are for emergency, non-emergency, and unscheduled visit or consultation at or away from the medical doctor's rooms or home, may not be coded together with item codes 1205 to 1207, and combinations of 1204 to 1210 are not allowed. The ventilation coding may or may not be added to these codes. The surgeon who performed the procedure may not code any post-operative care unless there is a complication post-operatively. Okay, and then the South African Cardiothoracic Society guidelines for code 1204 and 1205. Okay, so the major thoracic operations, according to the South African Cardiothoracic Society, requires post-operative ICU care, which should best be provided by the cardiothoracic surgeon, as he or she is most trained and experienced in this field. So only item codes 1205, 1204, and 1205 are exempt from Rule G at this stage. Rule G still applies to item codes 1205 to 1206 to 1210, and SAMA is also aligned to the society's guideline on this. Okay, and then we go on to the category 3 ICU code. It's the code range from code 1208 to code 1210. And this code range is appropriate for multidisciplinary team care for multiple organ failure, or for category 2 patients requiring active system support and that require multidisciplinary team care. Examples of this is a patient on ventilation and on dialysis who is being managed by a multidisciplinary team, or a patient with kidney failure, heart failure, respiratory failure, and this includes ventilation, who is receiving dialysis and who is being managed by multiple medical doctors. The MDCM does not make a distinction between acute and chronic organ failure. Therefore, both acute and chronic organ failure are both included here in the interpretation.
Sorry, Desh,
Yes.
can you try and sit a bit further away from the microphone and see if that's the problem?
Okay. Now?
It's clear now.
Is it clear? Oh, I'm so sorry. So,
When
all right.
when you start speaking, it goes all static on this side. So
Okay, so
we
that
just
was
want to
the
try
problem.
everything that we can. Maybe you can give the
Yeah.
laptop a little slap or something. I don't know.
Okay, now it's too late. I just have one slide more to complete. So yeah, sorry about the poor sound quality. All right, then we are still on category 3 ICU codes, code 1208 to 1210. And just bearing in mind, this note that that you keep seeing in red, that the doctors must discuss among themselves who will be recognized as the primary doctor and what category of ICU to code per day, or in each case. There's a lot of confusion that comes about because the primary doctor cannot be identified, or the category of the ICU is not agreed on by the multidisciplinary team. So each medical doctor that is involved in the care of the patient may code a different category of ICU, and it then results in a lot of rejections from medical schemes and so on. So it's important to just understand that aspect. Okay, then correct coding application for 1208 to 1210. For day 1, code 1208 may be coded for the primary medical doctor only, and all other involved medical doctors should code 1209, including the operating surgeon, should a post-operative complication be treated. And there, we need an additional ICD-10 code should be reported on the account. And then from day 2 onwards, code 1210 may be coded for each medical doctor who is part of the multidisciplinary team. So if a second medical doctor assists with an area that the first medical doctor cannot manage alone, that is, perhaps there's a nephrologist that is managing a complex dialysis patient, but the primary medical doctor still manages the other primary condition or conditions, then 1210 may be coded by each involved medical doctor. And here again, each of these codes, that is code 1208 to 1210, may only be coded once a day. And the add-on codes, the codes for the emergency, non-emergency, and unscheduled visit or consultation at or away from the medical doctor's rooms or home. That is this code range of 0145 to 0147 and 0126 may not be coded together with code 1208 to 1210. And then the combination of 1208 to 1210 is again not allowed by the same medical doctor on the same day. And lastly, and also very importantly, is that item 1208 to 1210 includes cardiorespiratory resuscitation. And for further details on that, you can just refer to to rule R in the MDCM. And that is the end of my presentation. Thank you. The question and answer session will follow after this. Over to you, Benita.
Thank you for that, Deshri. The floor is now open for question and answers. Are there no questions?
Benita, there's currently no questions in the question box.
Okay, thank you, Deshri. Okay, please join me in welcoming our next speaker, Dr. Conrad Mashilwane, a distinguished obstetrician and gynecologist from KwaZulu-Natal. Dr. Mashilwane has over 2 decades of medical experience. He holds several leadership positions, including chairman and managing director of the Gynecology Management Group, director and head of business unit at KZN Specialist Network, and chairperson of SAMA Specialist Practice Committee. Dr. Mashilwane will take us through today's session on coding for a color Doppler. The floor is yours, Dr. Mashilwane.
Thank you, Benita. Let me just go to my slides here. Sorry, I just need to share. Okay, good. Share. And let me go from beginning. I hope you can see my slides.
We can see it. Thank you, Dr. Mashilwane.
Okay, so good evening, everybody. I'm here to discuss correct coding for color Doppler. We need to understand that this code is a very frequently audited code. And we need to understand that, medicine has evolved over the last 20 years. Ultrasound used to be the domain of radiology. And if you look at the SAMA MDCM, in the radiology section, radiologists are no longer are no longer on a SAMA platform. And they're using a 5-digit system. And now these codes are basically under our control for people outside radiology. And I think for both sides need to understand, the funders need to understand that medicine have evolved, that non-radiologists are using ultrasound more and more. And the clinicians need to also understand that they need to give guidance to administrators on how they use these codes. And just basically using a code nilly-willy without discussing with your society and engaging SAMA and giving them direction on how to mediate on these codes leaves us with lots of problems at SAMA. And obviously, just to start, we are clinicians. We obviously have to go to the back and look at the clinical issues around ultrasound, so that the administrators understand what is it we are doing. Doppler ultrasound is a non-invasive test that is used for the following purposes: evaluating blood flow, locating blood vessels, assessing tissue viability before and after surgery. This is just a broad outline. And basically what we're looking here, we are looking at a device. We use a device called a transducer, placed on the skin or directly on the tissues. A water-soluble gel is used to help sound waves travel. And these transducers emit high-frequency sound waves which bounce off moving red blood vessels. The device measures the echoes and the sorry, I just need to move this. It's in my way. Okay. So would I move this? Okay. Apologies. The device measures the echo. So I just cannot. Well, how do I? So I'm just trying to remove this. Renia, sorry, just apologize. Okay, I'll go. Apologies, guys. I'm trying to move because I can't see some of what I've written here on the slide. Okay, so that Renia, just help me. How do I move this? Like it's that it's in my way.
Dr. Mashilwane, I can't see anything that's in front of you because we can only see the presentation on this side. But is it not something that you can just maybe drag out of the way?
I'm trying to drag it out. Okay, it's gone now. Thank you. Okay. So the device measures the echoes and the Doppler effect. The Doppler effect basically is a change in frequency of sound waves to create a picture of the speed and direction of blood flow. The results can be heard as a swishing sound and seen as a real-time moving image on the screen. I'm just struggling here now to move. Okay, thank you. And then basically Doppler ultrasound may help with many conditions like blood clots, poor functioning valves in the leg veins, heart valve defects and congenital heart disease, cardiac disease, blocked artery, peripheral vascular disease, aneurysms, narrowing of arteries, intracardiac shunts, etc. And the advantages of a Doppler ultrasound that it's non-invasive, safe, real-time imaging, gives us accurate diagnostic images. It's an alternative to invasive procedures, and it's used for post-procedure and injury monitoring. It's painless and quick, and it saves lives in terms of fetal monitoring. The different types of Doppler ultrasound. The first one is a duplex Doppler, which refers to a combination of two different types of ultrasound technology. There's B mode that provides grayscale and atomic image, and there's a Doppler component, which is either spectral analysis of graphs of blood flow velocity or a color-coded blood flow on top of the B mode image graph. Then there's a continuous Doppler, which uses a single ultrasound beam to continuously transmit and receive sound waves to measure velocity. It measures accurately high velocities, but lacks the ability to specify exact location. And the typical use of continuous Doppler is cardiac ultrasound to assess high velocity flow in situations like aortic stenosis and regurgitation. Then you have your pulse Doppler, which sends short pulses and listens for echoes, allowing pinpoint of a specific locations, but it's limited in the maximum speed it can accurately measure due to aliasing, which is basically when a high frequency signal is confused for a low frequency signal. The typical use is vascular ultrasound to evaluate blood flow in specific parts of a vessel and to assess the extent of regurgitation in a valve. Then there's color Doppler, which involves the use of computer to convert the Doppler ultrasound into colored images of the blood vessels. The images represent the direction and speed of blood flow superimposed on a standard 2D image, making it easier for clinicians to interpret. And I'd just like to emphasize that medicine has evolved and the use of Doppler is basically has increased, and funders need to take that into consideration, especially that it's a safe procedure. It's relatively cheap as compared to doing an invasive procedure or doing imaging using CT scan or MRI. And in internal medicine, it's got a wide array of uses, including deep vein thrombosis, peripheral arterial disease, carotid artery disease, aneurysms, venous insufficiency, vascular injuries. And it's basically used to assess perfusion and functions of abdominal organs and thyroid conditions. It's also used in monitoring procedures, for example, in a guided procedure where you're mapping vessels and guiding a medical procedure like a biopsy. Other applications will include echocardiography, transcranial Doppler, and diabetic monitoring. General surgery, it's used in pre-op diagnosis for detection of blood clots, identifying narrowed or blocked arteries, assess overall circulation, e.g. in limbs undergoing orthopedic surgery or conditions like diabetes, mapping blood vessels, evaluating blood flow to organs to diagnose conditions like renal hypertension or assess transplant suitability. Intra-ops assessments to confirm vascular patency and organ perfusion, detect and manage vascular complications, guide surgical procedure and assess tumor vascularity, also determine surgical feasibility. In obstetrics, it's used in monitoring of high-risk pregnancies, assessing placental function, evaluating fetal well-being, detecting fetal distress, guiding timing of delivery, screening of aneuploidy, and monitoring of fetal heart rate. And the key vessels in obstetrics include umbilical artery, middle cerebral artery, ductus venosus, and uterine artery. It's increasingly being used in gynecology in the last basically 10 years Infertility specialists are using it to assess uterine lining before embryo transfer, diagnosis and management of ectopic pregnancy, and assessing ovarian and uterine vessels to assess blood flow in the uterine and ovarian arteries to help manage a variety of benign conditions like fibroids and also malignant conditions. So I think funders need to be aware that this is becoming a common everyday tool to doing specialized work. And then in urology, it's used to manage Peyronie's disease, kidney disorders, acute scrotum, tumors, bladder, and other conditions. Orthopedic surgery, vascular assessment, deep vein thrombosis, inflammation and neovascularity, guiding injection procedures, post-operative monitoring, soft tissue mass characterization, and dynamic assessment. I think it's important that when you are a clinician, you have to seek guidance and evidence from your clinical society. It's no use just doing very highly specialized work on your own in your practice without understanding what's going on in other practices. And because when you get into trouble, it's only your society who's going to come and help you. And where you are providing a unique or outlier or novel technique or services as compared to your colleagues, you need to make sure that you take that into consideration, that you consult your peers and the experts to support you when you consider an outlier because you are in a unique situation. And you must request peer review in the circumstances of an audit where there's a query from a funder, because funders are not clinical experts, they are funding experts. And therefore, when they come to you, they need to give you an opportunity to get a peer review rather than just going into an audit and engage in very complex issues with administrators. If we look at color Doppler, this code has evolved over the last, let's say, 20 years. This is what code, color Doppler code 3637 looks like in RPL 2006. It's just color Doppler basically may be added onto any other regional exam, but not to be added to items 3605, 5110, 5111, 5112, 5113 or 5114. That's what it looks like. And this code has evolved. For example, if you look at the additions, this is 2016 summer MDCM. It says that it may not be added to any other outstanding item, maybe added to any other outstanding item if both a waveform and color studies are performed. This item 3637 is related to a peripheral vascular scan, either carotid or femoral, and may not be coded with any kind of examination. So obviously, as clinicians, we must approach SAMA, make sure that the codes are written in how we practice in medicine today, not 10 years ago, not 15 years ago. The gynecologists, they came to SAMA and to say, look, we need a Doppler code. Because maybe 20 years ago, when I started practice, none of us generalists were doing Doppler ultrasound. But increasingly, the generalists are now using Dopplers to assess the fetus, etc. And therefore, the gynecologist came and said, please, we would require a specific code for Doppler. And look, it was added, appropriate for Doppler velocimetry, fetal and umbilical artery. So the gynecologists protected themselves and made sure they go to SAMA and specify what code they want, because this is a radiology code. And there was no Doppler code in the obstetric section. And therefore, when your profession is evolving, you have to make sure that SAMA is, as an administrator, is evolving with your work. Now, this is 2025. The gynecologist decided now that fetal medicine has evolved. They want specific codes for obstetrics, and these radiology codes are no longer appropriate for use in obstetrics. And even if you look at the RVU for code 3637 is 78 units. Now, as the machines evolve, the technique become much easier and easier. Now, for the gynecologist would say, look, 78 RVUs is quite high for this type of procedure, because the ultrasounds are now becoming highly, the technology is improved. And therefore, they basically believe that the RVU should be lower. And then these are the codes now that the gynecologists have actually put onto the SAMA MBCM. Some funders accepted, some funders have not. But basically, the issue is it's your profession, it's your clinical work. It's not that administrators telling you what to do, it's you telling the administrators on how a code should be used. Now, there's obviously another code, 3635. It's written like this in the SAMA MBCM since 2006. Basically, there's not much information on this code. I'm not sure who's using this code. So if you are using a code like this, 3635 is a Doppler code, and you're not a radiologist, you have to go to SAMA and give SAMA direction. At the moment, there's not much direction on use of this code. And I don't actually see other professions besides obstetrics and gynecology directing SAMA on how they want to use these codes, which has become the problem that you are being audited all of a sudden. Now we have to wake up and understand what you're doing with these codes. And the color Doppler, this is how this code is written in the current SAMA MDCM, that obviously you can't use it obviously with a mammography 3605 mammography code. Now, I'm not sure if there's anybody outside radiology who's actually doing mammography, but you have to be careful that you can't add it on in a mammography code when you're coding for a mammography. For example, you've got other codes that you can use 3637 with, like 5110, which is for carotid ultrasound, vascular study, B-mode, pulse Doppler, and color Doppler. I'm not going to go into the guidelines, but you have to know your code. When you're using a code, you must look at that code and make sure that it's appropriate for you. And then you go to SAMA and you instruct SAMA on how to modify a code so it's appropriate for your profession. I'm only a gynecologist. I cannot speak for urology, for internal medicine. I can only speak for my profession. 5111, you can't use it with 3637. 5112, this is a peripheral arterial ultrasound vascular study, basically with B-mode, pulse, and color Doppler. 5113 is not to be used with 3637. If, for example, there's a vascular surgeon who basically is doing his own Dopplers, they have to be take into consideration that the color Doppler is already included in the 5113. 5114 as well. We expect the vascular surgeons to be using these codes quite a lot. So, for example, the gynecologists, they basically develop their own Doppler, own ultrasound codes and own Doppler codes. You can see, for example, 6481, Doppler umbilical artery is a frequently used code. Even if you don't bill for it, we're actually performing. It's an important study in patients where you suspect first trimester issues late trimester issues. We frequently have to rely on an umbilical artery. I'm not going to go into the clinical issues here. And 6482, middle cerebral artery. That's also important for fetal surveillance in growth restriction and in fetal anemia. And we rely on these codes. You know, these codes are so a RVU for these codes is about 10 units. But these codes can save funders a lot of money by just doing a Doppler for a 1 RVU. You are able to delay delivering a preterm baby and exposing the funder to these huge costs of ICU. And therefore, you know, funders have to understand that these codes save lives and they actually save them a lot of money. Doppler ductus venosus code that's used also in early pregnancy and late pregnancy as well. So these codes are there. The gynecologist, with the help of SASUOG, the Maternal-Fetal Society, took a lot of time developing these codes. And we have some funders who've accepted all the codes, and some funders are still trying to understand the benefit for them. There's a lot of benefit because we're saving lives and we're saving funders money. By saving ICU costs, there's a lot of money that's being saved, and we see a lot of value for funders here. And you see, we've also developed new codes for fetal maternal specialists. They're doing echoes with colored Doppler. Medicine has evolved. We have to stay on track if we are going to be improving outcomes, which is what funders are asking for. And I think really what's important with ultrasound, funders have a problem because, it's not like when you're doing a hysterectomy where you can just send a specimen to a pathology and get a report, an objective report that you actually did this hysterectomy. When you're doing an ultrasound, nobody can see what you are doing. And therefore, we are prone to abusing these codes. And therefore, it's important that you keep your images that you when you've performed a Doppler, keep your images and keep them, because not only is it an ethical obligation, but when funders come after 3 years and asking you for your images because they think you are abusing the code, at least that you've got something to prove that you've done the work, and you obviously must keep proper notes and justify. And it's no use. We don't encourage funders to intimidate our members where there's overuse. I think it's about understanding the practice, doing profiling the practice, looking at the unique situation that the funder the provider is in, and not assuming that it's basically fraudulent behavior. I think that was my last slide. Thank you very much.
Thank you, Dr. Mashilwane. Are there any questions regarding the coding of a color Doppler?
I'm just saying you are please welcome to drop us an email at SAMA where you believe that you require more clarification. These are really old codes. And we encourage the societies to come to us and update them for your need, and not for radiology, but for your need. Thank you.
Thank you, everyone. There are 2 questions that have been posted, but this is regarding the ICU visits. Okay, so the first one is, what about a prolonged resuscitation for 2 hours? Add-on codes. So the question is, will add-on codes be applicable to prolonged resuscitation? I'm going to hand over to our panelists to answer this.
Brenda, are you willing to take that question?
Yes,
Karen?
yes, I am.
Thank you.
Unfortunately, there is no time connected to that. There's only specific criteria, and you're not allowed to charge that with any ICU. So it is problematic, and I suppose this is something that have to be looked at. Thank you.
Thank you, Brenda. Karen, would you like to add input to that?
Yeah, I agree with Brenda. If patient is in ICU category 3, codes 1208, 1209, and 1210, obviously you cannot add separately for cardiopulmonary resuscitation. However, if that patient is in high care, 1204, 1205, 1206, or 1207, you can add cardiopulmonary resuscitation separately, up to a total of 150 clinical units per doctor involved with a resus. That being said, you are allowed to bill extra for the insertion of a CVP line for the insertion of an A-line or for the insertion of any intercostal drains that needs to be done during that resuscitation. But there is no add-on codes, as Brenda has said, that you can add on to that for any longer period of resuscitation. Thank you so much.
Thank you, Karen. There is one more question. If a doctor is covering the primary physical on call, is there any code they can use if they give emergency care?
Can you give that to Brenda again?
Brenda?
I'm sorry, is that emergency in the emergency unit? Or, I mean, for emergency, they will obviously have to charge code 0146 if they charge the normal consultative codes 01290293. But if this is in the hospital setting, again, they allowed to charge the add-on code 0147, as I understand this question. Maybe they can clarify what exactly they're looking for. Thank you, Benita.
Thank you, Brenda. Karen, do you have anything to add to that?
No, thank you, Benita. If we can just get more of a clarification regarding the question, I agree 100% with what Brenda has said.
Okay, I did receive clarification on that. In ICU, if the primary physician has latest coded for the day. Okay, Brenda, the question will be emailed to you. Okay, doctor, okay, then there's one more question. Can you code 1205 ventilation and 1117 intubation together? Okay, so the question is now, can you code 1212 and 1117 together? So can you code for ventilation and intubation together?
Benita, since I can remember, you're not allowed to charge for intubation while you're doing the actual ventilation. So it all depends. Was this done before the ventilation? It means maybe in the emergency unit, and the patient has been transferred to ICU where the ventilation will be then executed. It all depends. But you're not allowed to, the practice will not be allowed to charge both codes. That's it. It will happen when there are two different disciplines involved, two different doctors. Thank you.
Thank you, Brenda. Thank you, Brenda. Dr. Mashulwane, there is a question for you. Earlier, it was mentioned that item 3625 is no longer used, but we as cardiologists use it as part of our echo coding. Is this now an issue, or did I misunderstand the statement about 3625?
3625, did I include it in my... It was 3605. I don't remember speaking about 3625. There was a 3605. Obviously, I'm not a user of these codes. Now, we obviously would like to the cardiologist to guide us. Remember, we just basically handle the issues as they come from the funders. So I'm not going to be able to answer that for you and give you a specific answer, but I'm going to say, you basically have to tell us at SAMA, write us an email and say, look, I've got issues with this code. If it's 3625, we're going to have to look at it, and because these are radiology codes. They look at this code and say 362, there's an issue, please send us an email. I can't answer that question, unfortunately, because it's your work, and therefore you have to guide us at SAMA, and we sit around and make a decision. And if there's clinical basis, then we assist you in aligning it. Because it's a radiology code. You come to us and request that we need this code for our work. Did I help? Did I make things easier or more difficult?
Thank you, Dr. Mashulwane. I'll just repeat the email address to which the coding inquiries can be directed. It is coding@samedical.org. Okay, we're going to move on to our last speaker, Dr. Gregory Pratt. Dr. Pratt is a medical doctor. He provides medical advisory services to multiple open and closed schemes. He is also a certified fraud examiner and has over 15 years of experience in forensic auditing of healthcare practices. And he is currently the head of claims risk management at Momentum Help Group. Thank you, Dr. Pratt.
Good evening, everyone. Just give me a minute. Okay. All right. I'll move on quickly from here. Not too many slides to cover, and my topic was on the emergencies using code 0146. So when you look through your SAMA billing guide, this is the section that you will come across. It gives a descriptor of the code. It has 8 RVUs, and we have various explanatory notes that I will go through in the subsequent slides. So this code is intended to give additional remuneration for the extra time and effort spent in dealing with patients, that have some emergency situation. And it's specifically reserved for use at the medical doctor's rooms or for consultations that happen at a 24-hour casualty unit. You can add them to add this code to the consultation fees in the rooms, which are normally the 0190 to 0193. And they can also be added to the psychiatric codes, also to anesthetist consult fees, which are billed under 0151 and 0153. And that's typically where a case has been added to an elective list at short notice, because the anesthetists don't operate from rooms, so to speak. They generally see patients in the hospital already. One of these additional codes can only be used with a consult fee for an event, and this has been mentioned before. You can't bill 2 different kinds of emergency fees in addition to consults. Only one of those codes will be applicable. Just to bear in mind, these alternative codes have their own context. When we talk about 0145, those are non-emergency consults away from the rooms. You have your 0147, which is an emergency consult away from the rooms. And then the 0126 that is mentioned there is for unscheduled consults. And these are not valid when practices work on a first-come, first-served basis. You must have documentation to prove that there's an appointment system that works, and that you had to squeeze a patient in, into those appointment lists to validate this extra fee being funded by a scheme. Some schemes may not fund this code, but others do. So the bigger question then is, so what is an emergency consultation? We have the Medical Schemes Act, that defines an emergency medical condition as follows, and it requires these specific elements: that it's a sudden and at the time unexpected onset of a health condition that requires immediate medical or surgical treatment. These patients should not be left to wait, on the side until you are available to see them. They need to be seen urgently. And where failure to provide that medical or surgical treatment would result in serious impairment to bodily functions or serious dysfunction of a body organ or part, or would place the person's life in serious jeopardy. So this must typically interrupt the booked schedule of other patients. What is not an emergency? So we've mentioned that any unscheduled patient, a walk-in patient who does not have those signs of any urgent clinical problems, patients that are seen for convenience after hours is not valid for this code. Patients in a hurry who want to be seen before others. We see all sorts of crazy reasons being given. Or patients who require longer consults than usual would not qualify as emergency. They must meet this definition, and that is used throughout our evaluation of emergencies. So what is then appropriate usage of this code? Typically, we look at benchmarking across claims data. There's various forms of tariff code benchmarking which are done during discipline-specific analyses, from a funding perspective. For example, we currently pay over 7,500 GPs in practice. And that's then there's many more thousand specialists that are funded on a monthly basis. So we have quite reliable data in terms of code utilization within specific disciplines. So for example, we have on 0146, we typically see a GP practice that less than 2% of their claims value in a usual setting is due to the use of 0146. And on 0147 as comparator, which is then emergencies away from the rooms, in the GP side, we see less than 1% of practice income for a usual GP practice. So that where this utilization of the specific code exceeds these norms, that is when we would find an audit being triggered, and that's when we come potentially to a practice and to understand the circumstances and why usage of these emergency codes are different to what would be expected. The 24-hour casualties are accommodated because, as I said before, they can use this code for all their consultations in those units. And we can see those emergencies are validated by various consumables that are used in those events, including acute IV or IM meds, pathology and radiology investigations done on those patients, procedures billed at the same time. They typically, give a good indication that the patient had urgent clinical problems. And I mentioned a few different procedures over there. And then we can often see that patients were admitted into the hospital, which validates those emergencies. So, where we have background information, we can really, accept the codes without any issues. But typically in the out-of-hospital GP space, where the codes are used a little bit more often, well, let's say where they could be used in those practices, we don't often see the supportive claims from other practitioners or from facilities to validate those emergencies. And that's when a GP would have to, give us background should we require such. So that's really my story around the emergencies. It's not a very complicated one, and I think in the GP space specifically, 146 is not that widely used. In the specialist sphere, it's used even less because typically specialists don't see urgent patients in their rooms. They normally see them in a casualty or in the hospital setting. Thanks very much.
Thank you, Dr. Pratt. There is one question. Is there an add-on code for consultations of follow-up inpatients on weekends or public holidays?
Is there an add-on code for? Just repeat that.
Is there an add-on code for
Yes.
consultations of follow-up inpatients on weekends or public holidays?
So non-emergency follow-ups, that would typically be 0145, potentially, not 0146. But also these codes are not seen as after-hours codes or weekend codes. There's not a link to that aspect of these codes at all.
Thank you, Dr. Pratt. Are there any more questions for Dr. Pratt?
Benita, my hand is up.
Hey, Dr. Mashilwani, yes?
Dr. Pratt, I just want a clarification, this is actually a very important issue because it has attracted a lot of audits, the 0146. We need to, if you look at the wording of 0146, it speaks about an emergency consultation. I think you'd agree with me that it's an emergency consultation.
Yes.
And we need to differentiate an emergency consultation from an emergency health condition. Because a patient comes to your practice with an emergency symptom. They present to you and you don't know whether the patient actually has an emergency condition. So she comes to your office and she says, I've got excruciating abdominal pain, and I have to now see her urgently. I examine her and everything is fine. But then I've done an emergency consultation and I don't admit the patient. We frequently get that as gynecologists, patients come and tell the doctor, my baby is not moving. I want to see you now. And then you see them, you assess them and you say, look, there's no problem, but it's an emergency consultation, but there's no emergency health condition. And sometimes you get audited because the ICD doesn't look correct, but you've used 0146, which is a problem because you've attended to an emergency consultation and you made a diagnosis of normal. And in that case, you should be awarded as an emergency consultation because it's disturbed your work. And obviously you need to keep good notes. But I don't think that the funders should pounce on you and just, we had one funder who just basically just did clawbacks because the ICDs were not correct. Then we said, no, but this is not an emergency health condition. It was an emergency consultation. Thank you.
Yes, I think ICDs don't indicate severity very well. And often practitioners rely on a single ICD and don't give much further context. So as long as that situation can be explained or demonstrated that it did disrupt your appointment schedule, you had to attend to this patient more urgently, I can't see that would be a problem. I disagree that any audit should make assumptions based on data alone. They should always engage a practitioner and to understand the context of claims before making any finding on it.
Thank you. I'm glad. I mean, I agree with your answer. Thank you very much.
Conrad, may I just answer on or just give more feedback on that. It's actually, it is a bona fide emergency perceived by the doctor or the specialist. And that's why it not necessarily be questioned. And it will be clarified if it's questioned. Thank you.
Thank you, Brenda.
Okay, there are two more questions. Can you bill an emergency consultation with an ICU or high care admission?
I think if I can maybe give a comment there. So if you are seeing the patient already in ICU, then the answer is no. And Brenda, correct me if I'm wrong. If you are seeing a patient prior to ICU and you're doing a first consultation, then you can add those emergency codes. And then usually the patient is transferred to ICU, and then you would bill the ICU code. So the emergency code would apply to the first consultation, which is normally done under 0173 or 4 or 5.
Yes, I agree. I agree with that. Thank you.
Thank you, Brenda. There is one more question. Patient see a GP and GP phones specialist and says, please see the patient today with acute abdomen. Is that an emergency?
Yes, well, acute abdomen would be an emergency.
Thank you, Dr. Pratt.
And just to comment, Benita, on that, obviously the specialist needs to show that it's an emergency. So if somebody says acute abdomen and then you now you come in your office in the morning and you go see the patient at night after you finished your patients, then it becomes, they're gonna question it. You should also show that it was an emergency. So it's how you react is actually probably even more important than what you are told. Because sometimes somebody may tell you, this is not emergency, but you think it's an emergency and you leave your office and see that patient, that converts into an emergency because, as Brenda had said, it's it's a bona fide, what, Brenda, how you put it, bona fide emergency. Yeah.
Yes.
Thank you.
And of course, it's all depending on your clinical notes.
Yes.
Thank you, Brenda and Dr. Mashilwane for that. Okay, before we close, I would just like to make mention of the Section 59 dialogue. I'm sure you all saw the poll that popped up. This will be held on the 19th of November. Sama would like to understand doctors' experiences and perspectives regarding the Section 59 implementation, as well as your input on some of the aspects raised. Your input will remain anonymous. Please complete the questionnaire, and you are all invited to attend the Section 59 dialogue on the 19th of November at the Capital Empire in Sandton. Please register for this event as well. Thank you to everyone for participating in today's session, and a special thanks to Dr. Mashilwane, Dr. Pratt, and Deshri Munyan, as well as to our panelists for such an insightful presentation. Please remember to complete the post-webinar questionnaire. Thank you everyone for joining, and we look forward to seeing you again at our future webinars. Have a great evening ahead.
Thank you, Sama. It was a great evening. Thank you.
Thank you. Thanks.
Thank you so much, everyone.
Thank you.
Thank you, Benita.
Bye-bye.
I think we can just give them a couple of more minutes to complete the poll. Just give them a couple of minutes so they can complete the poll. A couple of people have already done so. Just a couple of more minutes. Thank you.
Thank you.
Oh, sorry, while we're waiting, is there time for one more question?
Yeah, we've actually got time until past.
Okay, great. This question is regarding modifier 0007 that is not being paid. Is
Can you
there a
repeat that,
rejection
Benita?
reason? Modifier 0007 that is not being paid. Modifier 0007 is used to compensate the doctor for using their own equipment. So can we maybe have a little bit more information on how this code is being used and what is the rejection reason, please?
Benita, who were you directing that question to?
Okay, this question came from Muzorewa Mbekle. Modifier 0007 is not being paid, so we just want a little bit more information on how this modifier is being used, how it's being coded, and what are the rejection reasons on this code. Okay.
Is the
It
doctor
is
able to
used,
speak? Or
the response received is, I use my own TCI pumps for anesthesia. Karen, would you like to give input on this one?
I think you're putting me on the spot here, but TCI pumps for anesthesia, it is using of own equipment in the rooms, if I'm not reading the modifier incorrectly. So modifier 0007 is performing procedures in your room. So if the doctor can just clarify if
Karen,
he's using the
there are
anesthesia
two-
pumps in his rooms or not.
Karen, there are two. There's modifier 0007. I'm reading it now. There's A and B. A is
Yeah,
using your own monitoring equipment in the rooms, and B is in use own equipment in hospital theaters or unattached theater unit. So it's both.
unattached theater unit. Well,
Yeah, hospital theater or unattached theater unit.
it's very possible, Conrad, and I'm taking this by a whim, that the hospital does have their own equipment and that the funder is not aware of the fact that the doctor is using his own equipment. So it might be a communication issue. If you are using your own equipment, I would suggest that you contact the funder and explain to them that you do use your own equipment. They would probably ask for a receipt that you have bought the equipment yourself and that it is yours, and take it up with the funder from that point of view. That would be my suggestion.
Or just drop coding unit at SAMA an email, and obviously we'll assist the SAMA member to investigate. Because obviously we need context, and as Karen has said.
Okay, there's one more question. Which code to bill for administering flu vaccine?
Brenda or Karen, can you help us there, please?
Conrad, I'm paging. Give me 2 seconds. I don't
it's a
know the
spot-
codes off
put on
by
the
heart.
spot, yeah. Yes. Okay, Brenda's disappeared, so you're on your, yeah.
I'm on my own, yeah.
Yes.
Yes. The administration of a flu vaccine forms part of the consultation. So it's not, it should not be coded in addition to the consultation.
Karen, are you in agreement? Deshri, are you in
Uh,
agreement?
Give me 2 seconds. Yeah. Yeah, I would agree 100% with Benita. that it is part of the consultation fee for the flu vaccination. The patient would probably buy the flu vaccination themselves and then take it to the doctor. If the doctor dispenses it, then he needs to follow the dispensing rules for billing for the actual medication. But he cannot bill separately for giving the flu injection to the patient.
Yeah, it seems that's correct because it's just under Rule A. That's Rule A actually. I think Benita, thanks. I think that's correct. Yeah, that
Okay.
treatment. Yeah.
Thank you. There's one more question. What is the correct code to bill for a PEG tube? That is for percutaneous, what is it? Enteral or enteral gastric tube. Insertion of a PEG tube. Percutaneous endoscopic gastrostomy.
Benita, I think let's take that as an email question so that we can just go through the rules and make sure that we answer that one correctly. I'm not sure if there is a specific PEG code, but I think it would be prudent if we can just double check and not give the wrong answer regarding a PEG tube.
Yes, that is correct, Karen. There's actually a range of codes in the MDCM. So if we can maybe get an opportunity to respond to that email, to that question via email. The email address is coding@samedical.org. Any more questions? The floor is open for questions and answers.
Yeah, Benito, I think it's safe to close the poll because almost 50% of the people that attended the session answered the poll. So I think that's quite good. It's up to you.
There's no further questions. Okay, I think we can close it then.
Thank you, Benita.
Okay, thank you everybody for your participation in our webinar. Have a good evening, everyone.
Thank you, Benita. Go well, everyone.
Bye.
Thanks. Goodbye.
Thank you. Bye-bye.
Yeah, bye.